Postmenopausal bleeding. A 53-year-old woman, Mrs. ABC, residing in Kolyanur, who's a housewife, belonging to socioeconomic class upper lower, P to L2 non-tubectomized woman, came with chief complaints of bleeding per vaginum on and off since 4 months. So, history of presenting illness, the patient was apparently well before 4 months, after which she noticed bleeding per vaginum, which was unprovoked, and it was initially spotting per vagina for 4 months back, where she used to have 1 pad per day, and it lasted for 2 to 3 days. Later, patient noticed gradual increase in quantity and increase in duration of bleeding per vaginum in successive months, where she used 4 pads per day and bleeding for 5 to 6 days. There was no history of passage of clots, not associated with abdominal pain, or discharge per vaginum, or mass descending per vaginum, or mass per abdomen. The patient had attained menopause 2 years back.
Madhu, is it okay if I call you Madhu? You just go to the first slide. Yeah, she is a 53-year-old lady. And when did you examine her? See, not for this particular discussion, but when you present a case in the examination, the date of admission and date of examination has to be mentioned without fail. There could be a lot of changes that would happen from the day of admission to the day of examination in cases wherein you can give some kind of palliation. A patient who had come with excessive bleeding right now would not have any bleeding. Patient who had come with anemia, maybe without anemia when you see her because of 1 or 2 blood transfusions, and the patient who comes with hypertension could have a well controlled blood pressure and you record it and find the pressures to be normal. So this information is very important. She's 53, right? Next one. And here it is also important to make a mention of say something about her husband, which will indirectly tell us 2 things. One is that she is married. Second is that she is probably sexually active, a 53-year-old lady. And para to living to, you have mentioned, you might ask me, I have written para to living to, so why should we bother about the marriage? I think you understand why I really ask for these things. Right, next slide. And here, see a 53-year-old lady presenting with bleeding PV on and off since 4 months. So you said your case is a postmenopausal bleeding. So straight away here, you should make us understand that it is a postmenopausal bleeding. So that is lacking here. Patient had attained menopause 3 years ago, and now she has presented to us with bleeding on and off since 4 months. In the exam, you will not be mentioning in the beginning that, Madam, sir, I am presenting a case of postmenopausal bleeding. You won't be telling so. So it should be introduced in the beginning itself that you are presenting a case of postmenopausal bleeding here, not by declaring the diagnosis, but as a chief complaint. See, anybody, if you feel she is regularly menstruating, is she much worried about on and off bleeding per vaginum, which is probably okay in a perimenopausal age group? So here, once you say patient had attained menopause 3 years ago, and now she has come back with on and off bleeding per vaginum, then it means something to us. So here itself, the mention should come. You have maintained the secrecy till the end of the next slide. That's not required here, Madhu.
Oh, okay, sir. Okay.
Next slide. She was apparently well before 4 months and she noticed bleeding PV unprovoked. What do you mean by that word? And why did you put that word?
Sir, there was no history of trauma, and the patient was sexually inactive for the last 5 years, sir. So
Okay. So Here, I think you can straight away make a mention that there is no history of postcoital bleeding after this. Okay, so she noticed, you can in fact use the word, the patient was apparently well before 4 months, then she spontaneously noticed bleeding per vaginum. Unprovoked bleeding, I think a provoked bleeding is very, very rare, excepting for postcoital bleeding. Women coming to us with history of trauma, I might have seen in the whole of my 25 years of OBG service once or twice. Okay, so it's not a very common thing to occur. So don't make a mention that it is unprovoked. Instead, you can say it is a spontaneous bleeding, which also conveys the same thing, right? And what does the next sentence say, and what do you really want to get the information from the second information that you have asked for? The very second line.
So initially the bleeding was minimal in quantity and it increased
Hmm.
in.
So does it give you any idea? And when you go to the next paragraph, there was almost a monthly bleeding as per your statement. Am I right?
Yes, sir.
In the successive months, the quantity and duration of bleeding gradually increased. Was it cyclical or acyclical?
It was not cyclical, sir. The patient said it may occur or it will come and go. She
So
didn't
she
know
was
it.
not sure about the cyclicity of this particular bleeding, but definitely she is aware that every time she bleeds, the quantity has been more, and even probably the duration of bleeding also has been more, isn't it?
Yes, sir. Yes, sir.
So what does it tell you? Dr. Madhu, the moment you get a case of postmenopausal bleeding, what both yourself and the patient is worried about?
Carcinoma, sir.
Carcinoma. So here, which carcinoma is going to cause bleeding?
So both CA cervix and endometrial carcinoma, sir.
Excellent. Both CA cervix and endometrial carcinoma are the common causes for carcinoma. Even vaginal carcinoma can cause bleeding. Even ovarian hormone secreting tumors can cause bleeding. But we are first looking at two possibilities. One is CA cervix, other is CA endometrium. Does it give any clue that I am dealing either with CA cervix or CA endometrium in this case?
Sir, she's having postmenopausal bleeding, sir. Both
Okay.
CA cervix and CA endometrium, all the uh, is, is a specific symptom in these cases, sir. And with further history and examination, we can
No, no, no. We have not gone beyond this. We just know. One Dr. Kempegoda wanted to give an answer. He just rose his hand and left at that. Someone wants to answer, they can. Otherwise, see, Dr. Madhu, here what happens is, if the bleeding severity is increasing, too much of bleeding, you don't expect CA cervix to bleed like this, wherein they are going to have going to change 4 5 pads per day. It is almost always a blood stain discharge that you get rather than frank bleeding, except in terminal cases. Otherwise, this kind of bleeding is very typical of endometrial CA, or let me not even put it as CA, some endometrial pathology will be responsible for these things. Is that
okay,
clear? So if the
sir.
quantity is more, if the duration is increasing, and she has to use a couple of pads every day, which is going on increasing, you most often suspect the endometrial pathology rather than cervical pathology. Is that
Okay,
clear?
yes, sir.
Yes. Next, you have gone to the sentence, no history of passage of clots, not associated with pain abdomen, discharge per vagina, mass descending per vagina, or mass per abdomen. Could you just tell me why you asked these things?
The no history of passage of clots to
Hmm.
assess the level whether the patient is having heavy menstrual bleeding. There will be passage of clots, sir, and
Don't call it menstrual bleeding, heavy bleeding. Here it
heavy
is
bleeding.
not menstrual,
Yes, sir.
isn't it?
Yes, sir.
It is a postmenopausal bleeding. We don't know whether it is menstruation. So
Okay.
it must be a bleeding PV, whether it is so profuse that it is resulting in the formation of clots. So clots will tell you that the bleeding is heavy. That's it. Next, not associated with pain abdomen. Why did you ask?
Dysmenorrhea.
Why? Why did you ask that? Why does it give you any idea about the condition, or do you notice it in any particular diagnosis you need to have dysmenorrhea?
Um,
Are you suspecting only this one, malignancy?
no, sir. It may be endometrial hyperplasia, or it
Okay,
may be a polyp,
okay,
cervical or endometrial polyp.
okay. Yeah, see, two answers. One, they said there could be infection and there could be pyometra. Yes, but pyometra usually doesn't result in this kind of bleeding, and infection will usually manifest with something else like fever, and her main endometriosis, Kirti, very rare to find at 53, right? Fibroid, yes, maybe fibroid, and someone is giving the answer a spread of carcinoma. Okay, I don't say no to that, but not a very common entity to cause pain. Adenomyosis, again, Sharanya, is very, very, very rare. I'm getting a lot of answers for this question. See, dysmenorrhea in this case, someone answered. Can polyps cause this much of bleeding? Absolutely, they can cause, dear. If there is a submucous fibroid polyp, they can definitely cause, because fibroid is always a hyperestrogenic state, and hyperestrogenic state could have its effect on the endometrium also, and there could be associated endometrial hyperplasia. So they can lead to the polyp plus endometrial disease can definitely lead to heavy bleeding. So here, Madhu, your history of not associated with pain abdomen in a 53-year-old lady who has presented with postmenopausal bleeding will help you to probably to some extent rule out leiomyomas. Postmenopausal women also still can have leiomyoma, and torsion of a fibroid and things. Okay, we can think in an isolated way, but when it is associated with bleeding, you always try to relate the two and then come to a diagnosis. A polyp, or rather the subserous fibroid, is most often the cause for torsion, but it is not going to cause any kind of heavy bleeding. It has got no link with your endometrial cavity, so it won't cause any kind of bleeding, right? So
Okay, sir.
now let us go to the next symptom, discharge per vagina.
Uh, Sir,
Why did you ask discharge per vagina?
uh, in case of CA service, there will be foul smelling discharge, sir, and
Yes. See,
as
discharge per vagina, if there is a history, can the organizer just look into the fact there is a lot of echo coming of my
Yes,
voice
sir. Yes,
itself?
sir. Yes, sir. Ma'am, if are you using earphones or is it in loudspeaker, ma'am? If you're
okay, I'll use it.
Yes, ma'am. If you're using loudspeaker, please switch to earphones, ma'am.
Is it okay now?
Yeah, I think so. After I speak, I'll know it, because a lot of reflection was there of my own voice. Now it is better. Yeah. Um,
Okay.
the discharge per vagina is a very, very important symptom. And if the patient says yes for the history of discharge, see, when we view any condition with some symptoms, always try to relate the two first, and later on you can think of something else. If someone answers me, can it be candidiasis? Absolutely yes. In a 53-year-old lady, she can have a curdy discharge per vagina, but in this particular case, I want to relate it to the bleeding and discharge. If the bleeding was associated with any kind of discharge, I would immediately ask her, is it offensive? If some of you have seen any case of CA cervix, When the patient comes and just stands in front of you in the OPD, we suspect that this could be a case of CA cervix by the offensive smell that you notice, right? That is because of the necrosed tissues which get infected and getting discharged. They have a peculiar smell which will make us very comfortably diagnose a case of CA cervix. So always, history of discharge, if it is there, always ask whether it is blood stained, whether it is purulent, whether it is foul smelling. These things will point towards the possibility of a cancer cervix, or even uh, an infected polyp. Very common. You think that it is CA, but it turns out to be a benign polyp also. Yes, mass descending per vagina. Why did you ask this?
Sir, in case of prolapse,
Okay,
genital
prolapse,
organ
you expect
prolapse.
bleeding.
Sir, if there is ulcer, decubitus ulcer, can be bleeding, sir. Not this much, but bleeding.
Yes. Okay. No, I agree with you. You are fine. What you said was exactly the thing that happens if there is a decubitus ulcer along with prolapse. Yes, they can have bleeding. So cannot be really of this quantity, but you are right in asking that. Mass per abdomen. Why did you ask that?
Sir, in case of a fibroid or in case of CA endometrium, there will be the uterus size will be enlarged, sir.
Mhm. Okay. See, here you have to remember 2, 3 things. One is, as you rightly said, uterine leiomyoma or fibroid can present as a mass for abdomen. Number 2 is not endometrial carcinoma, dear. Usually, endometrial carcinoma rarely goes for beyond 12 to 14 weeks. It doesn't grow beyond that. And 2, 3 answers I got. Hormone secreting ovarian tumors. Yes, absolutely. If you have a granulosa cell tumor, a thecoma, fibromas, these things can present with mass per abdomen, and ovarian metastasis is a little rare entity, and even if it metastasizes to ovary, it won't be of the size of a mass per abdomen. The other important condition is pyometra or hematometra, in which usually this occurs with a growth in the endocervix causing cervical stenosis and then collection in the uterine cavity. These conditions can present as mass per abdomen. And now you want to reveal the secret that she is postmenopausal. This should not happen. This should come in the beginning itself. Am
Okay,
I
sir.
clear, Madhu?
Yes, sir.
Yes. What else? Anything else you have asked? Shall we go to the next slide?
Yes, sir.
Yeah.
The patient was sexually inactive for the last 5 years, and there was no history of similar complaints in the past, and no history of fatigue, no history of palpitations, no history of breathlessness, no history of trauma, no history of hot flushes, no history of loss of weight or loss of appetite.
Okay.
Sir, can I continue?
You can continue, but I want you to explain these things. Importance
Yes,
of these things.
Sir, the patient is sexually inactive means there is no history of the bleeding is not postcoital, sir. And
I
there was
can't ask postcoital. That's all.
yes, sir.
You can't say it is not postcoital. I
Postcoital.
will not know if the bleeding is a contact bleeding history is there or not. Cannot be elicited in this case because she is sexually not active. Right. Next. No history of similar complaints in the past. Why?
Sir, if the patient had similar complaints in the past, she would have gone for any investigations, and
Yes,
it would add a point to our diagnosis, sir. And
absolutely.
whether she had taken any treatment, it can alter the prognosis. We can look in that.
See, the first point is absolutely right. What you said, you may get some clue about the diagnosis. Second thing is, if you think if she has had any kind of cancer or something 1 year back, she would have kept quiet. She would have had a definitive treatment for that. If she is not hysterectomized or has not been given any definitive treatment, that means it could be some other benign problem. it might tell you that she is dealing with some reasonably benign issue. And even in case of benign issues, if the patient comes with recurrent bleeding, you may have to offer her a definitive treatment. So it may help us to decide about the mode of treatment. Is that clear, Madhu, what I said? If
Yes, sir.
previously she has had an atrophic endometrium, someone has done a biopsy and the report comes as atrophic endometrium, and after 2 years she has had one more episode of postmenopausal bleeding. So at this point of time, recurrent postmenopausal bleeding, in spite of benign pathology, we may have to consider for a definitive treatment. Okay, so that is the importance. I think fatigue, palpitations, breathlessness, all the things you wanted to know the effect of
Anemia.
bleeding,
Yes, sir.
anemia.
Anemia.
And trauma, you mentioned, and initially you said there is no provoked bleeding, so trauma is ruled out. You asked
Yes, sir.
about hot flashes. Why?
Sir, for menopausal symptoms, sir.
Okay, so when do you diagnose menopause?
Sir, it's a cessation of ovulatory function when the patient is not having menstrual bleeding for more than 12 months, sir.
More than
12 months, 1 year.
yeah, more than 1 year in a woman who is beyond 40. If she is less
Yes.
than 40, I won't make a diagnosis of just menopause. She should be above 40 and she should have a cessation of menstrual cycles for more than 1 year, and in whom pregnancy and reproductive events have been ruled out. Isn't
Yes,
it?
sir.
Physiological causes, other physiological causes of amenorrhea must have been ruled out, and she should be beyond 40 years. Then only I say she is menopausal. Okay. So what is the
Yes, sir.
average age of menopause in India?
Sir, it's 45 to 60, sir.
Okay. So on an average, it is supposed to be around 47.5. So what you said was okay, 45 to 50. When do you call a woman as postmenopausal in spite of continuing to menstruate? We get many women continuing to menstruate even beyond 47, 48, 50.
More than
Physiological cause
52,
of
sir.
amenorrhea, someone asked me. What is it? Physiological causes of amenorrhea are
Pregnancy,
prepubertal,
pre-pubertal.
pregnancy, lactation, right? And postmenopausal. All are physiological causes. And someone answered here, till what age you would give the margin and then only consider. I think Prajwal answered that it is 52
52
years.
years. Yes, sir.
Absolutely right. Beyond 52, even if the patient continues to have cycles, I would investigate that case as postmenopausal bleeding itself. Is that clear?
Yes, sir.
So 52 is taken as the cutoff for investigating a bleeding in a woman, even though she is not reached menopause. Yes, then you have asked about loss of weight and loss of appetite. So what is the importance?
So in case of cancer, there will be cachexia to rule out
Mhm.
that, sir.
Which cancer you find cachexia?
So in CA cervix, in
Mhm.
CA endometrium, there will be no loss of weight or loss of appetite. So the patient will be obese in contrast.
Very good, very good. In fact, in CA endometrium, you see lot of obesity rather than loss of weight and appetite. In case of CA cervix, when it reaches beyond stage 3, you may have cachexia. And most often in case of CA ovary, because we usually diagnose CA ovary in stage 3 and stage 4, you may encounter the patient who is cachexic. Okay.
Yes, sir.
Yes. Yes, Harini, you are right. Harini or Harini, I don't know. Sorry. So you are absolutely right. Patient is cachexic in ovarian cancer. Yes. Go ahead.
There is no history of bleeding tendencies anywhere else in the body. There is no history of pain and fever, no history of altered bowel and bladder functions, no history of OCP usage, no history of radiation, no history of hormone replacement therapy, and there is no history of previous investigations for cancer screening.
Okay. So bleeding tendencies, you wanted to rule out coagulopathies
Yes, sir.
or any
And
kind
also
of
bleeding per rectum and urethra.
okay. See, altered bowel and bladder functions, does it include any kind of bleeding per rectum or hematuria or any such thing? Do you want to mention those things?
Sir, yes, sir, and also pressure symptoms
No, no, no.
due
Just
to
my question
increased.
is very direct. Are you thinking of hematuria and bleeding per rectum also in a case of postmenopausal bleeding? Do you want to make a mention of these two symptoms?
Yes, sir, I want to rule out that, sir.
See, many a times women can present, think that the bleeding is from the vagina, where in fact it is from the rectum, because they may see their Sharanya. I am not talking about spread of CA cervix. I am just talking about primary lesion in the rectum itself. She sees her undergarment to be stained with blood. She is routinely used to expect that menstrual blood is the only thing that she brings out. So she may think this bleeding is from vagina, whereas in reality it is from rectum. Similarly, even there could be a small caruncle, small growth at the tip of the urethra. From there, the bleeding is occurring, but she misinterprets it as bleeding per vagina. So both history of any urinary bleeding or bleeding from the bowel, etc., should be very delicately, and you may have to really poke into this history properly and find out where exactly is the bleeding from, right? And pain and fever, why did you ask?
Sir, pyometras.
So pyometra, okay. And pyometra, again in this case, unlikely to cause bleeding, right? Then coming to OCP usage, why did you ask OCP usage?
Sir, OCP is protective against CA endometrium and CA ovary, sir. I want to
You
know
are
that
talking
patient is
about past
using
history or
any.
present history?
Sir, I want to know that patient is having any contraceptive usage, sir. And
Dr.
also,
Madhu, see,
sir,
here you should be little practical. You said patient is sexually not active for 5 years. Number one, she is not
previously,
pivectomized, you said, and she
yes,
has
sir.
attained menopause. Do you think any physician would advise OCP for such women?
No, sir. I want to
No, it is
previous in
not
past
practical.
history. Yes, sir.
OCP is not given to such women at all. Even otherwise, beyond 35, we hesitate to give OCP. Beyond 45, we usually avoid giving OCP even if the woman wants. And
Okay.
unfortunately, progesterone only pill is not available under the national program with us. So we may not offer them progesterone only pill. And basically think, why will she ask for OCP when she is not
Sexually.
sexually
Yes,
active?
sir. Sexual active.
Isn't it? So here it becomes little superfluous. Don't add such things just because OCP, someone wrote withdrawal bleeding. It is not exactly withdrawal. It could be something like a breakthrough bleeding. If they
Breakthrough
don't
bleeding.
take the tablets properly, they forget to take the tablets. In such cases, patients can have bleeding in between, but this happens most often in the reproductive age group, right?
Yes, sir.
And Harini again asked, can we consider HRT? And Dr. Madhu has mentioned it here, Harini. Just look here. She has written no history of hormone replacement therapy. It has to be considered. Hormone replacement therapy has to be considered because what are the types of hormone replacement therapy we know or we use? Just
Sir,
gross
estrogen only
classification,
or
Madhu.
both combined?
Absolutely wonderful. See, it is really good for an undergraduate to give this kind of answer. One is estrogen alone, the other is estrogen with progesterone. Most of the symptoms respond very well to estrogen. Then why do we give progesterone?
Sir, combined effects, sir. Estrogen alone is has many side effects, sir, like thromboembolism, and it is high estrogen causes many like see endometrium, and it predisposes the
See,
woman to
it is
many
very,
problems,
very
sir.
clear. A direct Manasi is answering. It is given to protect the endometrium. Okay, not more
Yes,
than the
sir.
other side effects. We are worried about its effect on the endometrium. So we always should give sequentially estrogen with progesterone. So, Dr. Harini's question whether HRT can be considered. Yes, if progesterone is not given properly, or if progesterone has been withheld, they have not given progesterone at all. In such cases, HRT could be the culprit for causing
Endo.
endometrial pathology. I don't say straight away cancer. It could be hyperplasia, or it could be endometrial cancer. And no history of previous investigations for cancer screening. Wonderful. She has not had a pap smear or anything earlier. So it's a very important information. If she has had any screening, then reasonably, if she says 10 years ago I had a screening for cancer and I was told that things are fine, you can reasonably keep the possibility of CA cervix aside and think of the rest of the things. So it's a very, very important and a good history here that you have given. Next, continue.
Yes, sir. Past menstrual history. The patient had attained menarche at the age of 13 years. It was a 28-day cycle. It was regular cycles. 5 days. The menstrual period lasts for 5 days. She used to have 3 pads per day, soaked fully, and it was not associated with clots or abdominal pain. There was no history of contraceptive usage.
Okay. In the past menstrual history, menarchal age, is it important?
Yes, sir. Because early menarche predisposes the high estrogen level predisposes
Yes,
to
anything that predisposes to continued and estrogen level, it is not to high estrogen level, it is prolonged estrogen
estrogen.
exposure, isn't it? Not that
Yes, sir.
early menarche will cause too much of high estrogen. It is the duration for which estrogen exposure happens. So 13 years of menarche is okay, or is it early menarche?
Less than 12, sir. Early menarche. 13
Indian
is a
average
little
now
bit.
is almost 11.5, Madhu. So there is, you can roughly say less than 10 years, you can take it as early menarche.
Okay,
Though
sir.
there, yes, Shruti answered, it is less than 10 and less than 10. Before 8, it is called precocious puberty,
Precocious puberty.
right? Before 10, it could be early, and after 10, it is normal menarche now. And late menopause is after 52.
52.
After
Yes, sir.
52, we take as late menopause. So your patient had menopause at
51, sir.
51 years. So it is reasonably okay. So there was no much of a thing to say that there was any early menarche or late menopause. And what is the importance of regular cycles?
Sir, there was no ovulatory in a younger age. There was no ovulatory pathology, sir. In PCOD, or the patient will have irregular cycle,
Mhm.
and
What is the effect?
sir,
Irregular cycles.
sir, estrogen,
It
prolonged
is
estrogen
unopposed
exposure,
estrogen.
unopposed
Try
estrogen.
to use proper words. Early menarche
Okay,
and
sir.
late menopause causes prolonged estrogen exposure. Irregular cycles will cause unopposed estrogen exposure, isn't it?
Yes, sir.
So her cycles have been regular, so no such problem. And if there is a history of any congestive dysmenorrhea, you have said not associated with clots and abdominal pain. If there is history of congestive dysmenorrhea, you will be thinking of three things. Congestive dysmenorrhea is
Fibroid,
due to fibroid, endometriosis,
endometriosis,
or PID. So
PID.
PID is not a hormone related one, whereas endometriosis and leiomyoma both are estrogen dependent. So probably if there is an association of these two conditions, then you can think the moment you get a history of dysmenorrhea, congestive dysmenorrhea, which says that quite before the flow begins, 3 to 5 days before the flow, she starts getting the pain, and the pain
During
continues throughout the cycle. Sometimes even after the cessation of bleeding, 1 or 2 days, it might continue. So this history is there. Immediately try to take the history of dyspareunia. Any, because if it is associated with dyspareunia, your diagnosis of endometriosis is very
Process.
closer. If she says mass per abdomen, or if she says I had a surgery, maybe a myomectomy. So
Maybe.
such things, those things will give you a clue. No history of contraceptive usage. Yes, tell me why you asked this. I think OC pill we explained. What about IUCD, Madhu?
Yes, sir. IUCD may cause irregular bleeding, heavy bleeding, sir. In
Proper IUCD can cause irregular bleeding. And one more important thing that you should remember is, see, Akshay is answering
maybe
retained
LNG.
IUCD. I did not say retained IUCD. I want to call it forgotten IUCD. Okay. No, nobody will. Yes, Sharanya is answering forgotten IUCD. I have seen two cases. One lady who was 59 years who visited me with history of continued bleeding, that she has not attained menopause with irregular cycles, brought by her daughter-in-laws. And this particular lady was examined in by two gynecologists. They had not done a speculum examination. In the beginning of my obstetric practice, this happened. And I had some great teachers who were very particular about gynec examination for every patient without pronouncing the diagnosis. So I said I have to do a speculum examination. The moment I did a speculum examination, I saw the thread. But when I asked the woman whether she has had any IUCD insertion, she said no. And the fun, in the whole of her life, during the birth of her second son, she had gone to the hospital. And other than that, she has not visited any other hospital, excepting for now, she is visiting the doctors for postmenopausal bleeding, or rather continued bleeding, I would call it. And so I was little reluctant to immediately try to remove it, because I guessed that at the birth of the second son, some doctor must have inserted the IUCD and not informed her at all. And that was the truth, in fact, but we could not really find any evidence for that. And I got a X-ray done. This was long back, so we had no scanning at that time. I was surprised to see a Lippis loop, the first generation IUCD.
Yes.
I gave her a course of antibiotics to relieve any kind of infection, and then finally I called her and removed it. From the very next month, she had amenorrhea. So history of forgot, I should not even get it in the history. I will only get it during my examination. So if the patient gives any history of insertion of an IUCD and doesn't remember anything beyond that, you may consider the possibility of a forgotten IUCD. Any of you have seen forgotten pessaries causing bleeding? Any of you have seen forgotten tennis ball or rubber ball in the vagina, which was inserted by some village quacks to treat prolapse? We have seen all these things in government institutions. I think Madhu also is from a government medical college. And
Yes, sir.
you stay in the department for a couple of months or years, you will see all these things. We had to apply a pair of forceps to remove that ball from the vagina. you know so anything is possible. And forgotten pessaries, again, are not really not rare. You may find on and off, in which everything mimics a cervix, foul smelling discharge for vagina. Okay, so foreign bodies in the vagina is one of the important cause for postmenopausal bleeding. Okay, so go to the menopausal history. In
Specialist.
fact, there is nothing like a menopausal history subheading, Dr. Madhu. So you can continue it in the menstrual history itself and say attained menopause at 51
Facet.
years, and you can say how it happened. This is really good. From 49 years, she had irregular cycles. Gradually, it stopped at 52 years, and no history
Sorry,
of.
sir. 51 years.
Fine,
Sorry.
you change it. That is fine. And no history of using any hormone replacement therapy. and whether you had mentioned that there is no history of any hot flashes. So you can make a mention once again, like hot intolerance, heat intolerance, then sweating, palpitations, tremors, and mood variations, urinary disturbances, all those things, and vaginal itching. All these things could be features of usually the genitourinary and vasomotor symptoms make their appearance in the beginning. So you can make a mention if you want, right?
Okay, sir.
So is that clear now about menstrual history? Yes, go ahead.
Yes, sir. Marital history. The patient married before 25 years and the patient conceived after 1 year of marriage.
Okay,
Can I proceed? Okay.
proceed.
Past obstetric history.
Hmm.
First child at 29 years. All the 3
Hello,
trimesters were
one second.
uneventful.
One
Sir?
second.
Yes,
I
sir.
just want to make a small suggestion. I really don't say that it is a correction, because maybe you have been taught like that. We usually teach students to put it as obstetric history. What do you mean by history? We talk about the past,
Past. Yes,
and
sir.
it is a gynec case. If you are telling history of present pregnancy, that is what we put here. When you say
Yes,
past
sir.
obstetric history, you're stressing too much. You can better say obstetric history. And
History.
obstetric history of a woman, at least an Indian woman, at least officially begins with marriage. Do you agree?
Yes, sir.
Hmm? So you start there is no need to mention marital history separately. You just put the heading as
Okay, sir.
obstetric history.
History.
My patient is married for the past 25 years, and go on, and
And
whether it is consanguineous or non-consanguineous becomes more relevant, especially in a case of in obstetric cases. And here then go for the first pregnancy, conceived 1 year after marriage, and
conceived
proceed.
spontaneously.
Okay,
Yes, sir. First
proceed.
child at 29 years of age. All trimester were uneventful. It was a male baby. Birth weight 2.5 kg, and the baby cried immediately after birth and breastfed within half an hour. It was a full-term vaginal delivery, and she breastfed her child for 1.5 years. Now the child's age is 24 years. And second child at 33 years of age. All the 3 trimester were uneventful, and it was a female baby. Birth weight 2.9 kg, and baby cried immediately after birth. She breastfed within half an hour, and she breastfed a child for 1.5 years. Sir. Now the child is 20 years. There was no antenatal, intrapartum, or postpartum complications, and the delivery was done in the nearby government hospital. Sterilization not done.
Okay, so here really this much of detail, it's welcome but not required. If there is anything significant, do you have you see any kind of significance in obstetric history in postmenopausal bleeding?
No, sir.
What points, in not in this case, what points become significant?
Sir, na- null- number of childbirths, sir, and
Okay, she is having periods of infertility,
yes, sir.
isn't it? If she has got periods of infertility, treatment for
For
infertility,
infertility.
yeah, and of course, sterilization has not been done. LSCS for uterine scar, the route of delivery probably should not really matter, but this may have a very small role in deciding about management. Nowadays, people can operate laparoscopically or by open methods or even by vagina with 2 or 3 scars on the uterus also. So it should not really matter, Sonakshi. So now obstetric history, I'm more worried about infertility, ovulation inductions. Ovulation induction, if I say, that means she is anovulatory. So she is probably having a couple of cycles with this one. Uh, Unopposed estrogen. And next is about breastfeeding. If she has breastfed for a little longer time, probably she's having no cycles. So again, the estrogen exposure is slightly less. Breastfeeding might have helped her, and even use of OC pills also would have protected her endometrium and ovary both, isn't it? So
Yes,
these
sir.
things we get. Otherwise, you can just say first one, full term normal hospital delivery, antenatal, intranatal, because whether it is a male baby or female baby, it should not really matter to me. I am really surprised at two things here. One is the first, the boy is 29 years, sorry, 24 years, and the girl is 20 years. First 4 years she has not used any contraception and she has managed not to conceive. And after the second baby, for 20 years, only for the past 5 years, she is not sexually active, but she has not conceived for 15 years. So, was it why she has not conceived? What is the issue here? Is really bothering me. Did you make any attempt to find out how this happened?
While saying history, she said they planned only for two child, so they
Fine,
stopped.
fine. So, what contraception was used by them? Nothing. You could not
Sir,
elicit.
no,
Okay,
sir, I didn't.
right. So this is really surprising. Was it vasectomy, Madhu?
No, sir,
Okay,
I didn't know anything. The patient didn't say anything, sir. I
right.
too didn't elicit.
No, you should because we should be little curious. How co-inhabiting for 15 years and not conceiving? Then they may say, I aborted two babies. Or they may say, my husband was using condoms. Some history you may get, and may or may not be significant for your particular case, but your history taking ability will improve. Yes, go to the next slide.
Okay, sir. Past history: the patient is a known case of diabetes mellitus for the past 5 years and is on regular oral medication, and she has no history of hypertension or thyroid disorders or bronchial asthma and PCOS. Family history: no history of breast, ovarian, colorectal, and endometrial cancer in family. No history of bleeding disorders.
Okay, so diabetes mellitus, will it have any significance?
Yes, sir. When it is present with other risk factors, it increases the risk up to 2.2 times, 3 times, sir, 2.8 times.
Okay, so diabetes mellitus increases the risk of endometrial carcinoma. That's what you want to say, right?
Yes, sir.
Yes. What are the other risk factors?
Uh, Early menarche,
No,
late
no, no, no,
menopause,
no, no. In
mm,
relation to diabetes, what else you want to?
hypertension.
Absolutely. Yes, Ravish answered corpus cancer syndrome. Can you
Syndrome.
explain that, Madhu?
Yes, sir. In obesity, hypertension, and diabetes in a female with mostly have endometrial cancer, sir.
No, no, no.
It's a triad.
Don't say so. Huh? In a case of endometrial cancer,
Endometrial cancer.
if
Yes, sir.
it is
Very well.
associated with diabetes mellitus, hypertension, and obesity, this particular condition is called corpus cancer syndrome.
Cancer
Okay,
syndrome.
not that with these three conditions they will have more of endometrial cancer. Endometrial cancer association with these three
These
conditions:
three. Sorry,
obesity,
sir. I
diabetes
reversed.
type 2 diabetes, and your hypertension. These together, we use the term corpus cancer syndrome, right? And
I
not a
reversed.
known case of hypertension, thyroid disorders. BA means
Bronchial asthma.
bronchial asthma, or PCOS. Um, Past history of PCOS, agreed, but I think this gets implied in your menstrual history. Past history we usually don't mention here. You can even mention it as no history of tuberculosis. Fine, but PCOS we
Yes, sir.
routinely do not mention, Madhu. Okay,
Sir, for this case, I mentioned.
yeah, yeah. A family history: breast, ovarian, colorectal, and endometrial. Why did you ask?
Sir, in hereditary cancers, in Lynch 2 syndrome,
Yes.
HNPPC is the
Yes,
gene
very good,
mutation.
very good, very good. So HNPCC and Lynch 2, in which you usually have, and of course BRCA. 1 and
Yes,
2
sir.
mutation also can be associated, and breast cancer could be associated because of the common pathogenetic mechanism, that is hyperestrogenic state.
Hyperestrogens.
So they can have, and ovarian, usually the endometrioid variety of cancer could be coexisting both in the ovary and in the endometrium. So you are perfectly right in asking about this history, and you have also asked about bleeding disorders in the
Disorder.
family. Fine. So here also, though for postmenopausal bleeding, this is for the benefit of all the students I'm telling, though we don't classically describe the palm coin classification for postmenopausal bleeding, there is no problem. It is not a mistake if you apply it. You need not mention it in your answer, but you try to rule out whether I am dealing with polyp. So how do I express that? How do I try to elicit the history? One is by intermenstrual bleeding, one is by say contact bleeding, other is by foul smelling discharge, last one is mass per vagina. Four things. One is bleeding itself, offensive discharge, mass per vaginum, and in regularly menstruating women, we ask about intermenstrual bleeding, right? Contact bleeding
Yes, sir.
also. All these things, if you find, it could be a case of CA cervix, or it could be a case of a polyp, right? Then adenomyosis is usually a disease of perimenopausal age group, and if you have a woman of 52 who has reached her menopause just 2 to 3 years ago, still adenomyosis could be an issue, but adenomyosis is most often associated with severe dysmenorrhea. If there is no dysmenorrhea, unlikely that you are dealing with adenomyosis. The third issue being leiomyomas. Yes, leiomyomas, especially specific variety like submucous fibroid, can present with this kind of issue. That is the very typical, like what you are seeing in your case, bleeding which is going on increasing. It could be a feature in submucous fibroid. And even, of course, intramural also can present with this kind of picture. And lastly, amongst palm, the malignancies. Yes, that is one thing which we are really worried. And Dr. Madhu has made an excellent attempt to rule out in the history. Can we consider leiomyoma in postmenopausal bleeding? Absolutely, Manasi. You have to consider leiomyomas in postmenopausal bleeding for the simple fact that leiomyomas cannot just overnight get dissolved in a menopausal woman. It continues to stay there, and because of the atrophy of the uterus, sometimes if the fibroid has undergone certain changes, it may not regress the way it has to regress. So uterus becomes small, the fibroid may remain like that, and an intramural fibroid may turn out to be a submucous fibroid because of the shrinkage of the uterus, but status quo condition of the leiomyoma. So these things can cause bleeding in a postmenopausal woman due to leiomyoma also. And when we talk about cancer, starting from vagina, vulva, very rare, but still they can, it could be there. There could be CA cervix, CA endometrium, CA fallopian tube. Yes, CA fallopian tube. If you go through the pathogenesis of ovarian cancer, you have got two varieties, type 1 and type 2. The type 2 variety comes, has its origin in the tubes, and then it spreads to the ovaries, and then totally it involves the ovaries, and we don't know is the primary from the tube or from the ovary. So it's a very aggressively growing cancer, which are called type 2 ovarian cancers. And so even fallopian tube cancer can start periodically discharging its contents into the uterus, and patient can have postmenopausal bleeding. Ovarian tumors can have postmenopausal bleeding if they are hormone secreting. So any case in which you have postmenopausal bleeding along with adnexal mass, think of hormone secreting tumors of the ovary. right? So PALM. And coming to coagulation disorders, very rare to have an onset at 50 or 52 coagulation disorders, but sometimes say the platelet disorders, what is it, um, autoimmune conditions and von Willebrand disease.
Willebrand disease.
Pardon?
Sir,
What,
no,
Madhu?
so von Willebrand.
Yes, Van Willebrand can make its appearance. I think if I am right, the type 2, you have three types of Van Willebrand. Type 2 can make its appearance in the perimenopausal age group. So you can have this kind of problem with Van Willebrand disease, right? And uh, some of the leukemias, chronic myeloid leukemia and chronic lymphatic leukemia can make their appearances at this age, and they can present with bleeding from any of the bleeding surfaces. Could be epistaxis, hemoptysis, hematemesis, bleeding per rectum, hematuria, and also bleeding from the genital system, which is again nothing but postmenopausal bleeding. Again, it is due to coagulation problems. So ovulatory we keep aside because the woman is not ovulating. This kind of thing cannot occur. Then coming to iatrogenic, I mentioned forgotten IUCD, hormone replacement therapy.
Replacement.
And see here, you said there is no history of breast or ovarian cancer in the family. Do you think the history of breast cancer in the patient herself, is it important?
Yes, sir.
Why?
Uh, Sir, the risk factors are same for
Risk
prolonged
factors are
estrogen.
same. Second is, yes, Sharanya, you are right. Tamoxifen usage.
Yes,
It
sir.
is very, very common to use tamoxifen in breast cancer, and tamoxifen is known to cause bleeding. It is known to increase the thickness of endometrium and can cause postmenopausal bleeding. Hence, history of breast cancer in the patient also is important. So again, it becomes iatrogenic, or your patient is a diabetic. If she says, 1 year back I had an myocardial infarction for which I have undergone angioplasty. Do you know post angioplasty? Usually, the patients are put on aspirin, they are put on antiplatelet agents, isn't it? So, again, one more iatrogenic cause for bleeding, right? So iatrogenic is the one, and of course not classifiable is the last one. And it becomes so simple, and while taking the history, where to put what, if you just methodically do it, your history will be perfect. And I really appreciate the way you have taken the history, Madhu. Most of the things are covered, and most of the things you were able to even reason out. Excellent presentation. Go ahead.
Yes, sir. So, personal history: the patient consumes vegetarian diet, sleep pattern normal,
Hmm?
bowel and bladder movements regular. She is
Hmm.
not a smoker, not an alcoholic.
Okay. So right, and again, don't forget to mention about no history of bleeding during urination, no history of bleeding per rectum also should be mentioned somewhere in the history without fail. Right.
Okay, sir. Summary: a 53-year-old postmenopausal female with chief complaints of bleeding per vaginum on and off since 4 months, which was gradual in onset and it progressively increased in quantity and duration, not associated with clots or abdominal pain, a known case of diabetes mellitus for the past 5 years and on regular medication, no family history of carcinoma.
Okay. Here she is a para to living to, isn't it? That you have not mentioned. It's important. She is not tubectomized, you have not mentioned, right?
Oh, yes, sir. Okay, sir.
So that should come. It has to be there. A 53-year-old para to living to, not tubectomized, who is postmenopausal. There itself, you are supposed to say that. Okay, fine.
Okay, sir.
Proceed.
Physical examination: The patient was examined after getting consent from the patient, and the patient is conscious, oriented, moderately built and nourished, pallor present, no icterus, no cyanosis, no clubbing, no lymphadenopathy. The patient's weight is 80 kg and height 155 centimeter, BMI 33.
33 kg per meter square. Put the unit without fail. And
Okay, sir.
here patient is conscious, oriented, moderately built and nourished. Hmm? So this is
Okay,
okay. Pallor is present, so it supports the symptom. No icterus. Why is it important?
liver metastasis.
Yeah, that is the only thing that we can think
We
of.
can.
And no cyanosis, no clubbing, all these things. See, chronic infection or pus somewhere collected, pyometra, you may notice clubbing. So that is not there. Lymphadenopathy, very rare to appreciate any palpable lymphadenopathy with the cancers that we have kept in mind, isn't
Yes, sir.
it? So unlikely, this is fine again. And can you have inguinal lymph nodes in any of these
Yes, sir.
conditions? Where?
In endometrial metastasis, sir,
Hmm.
and yes, sir, in abdominal tumor metastasis stage.
Usually, when it goes for inguinal nodes, most of the genital malignancies are stage 4.
Yes, sir.
It is considered as a distant metastasis. In ovarian cancer, you may notice metastasis in the supraclavicular lymph node, left
Lymph nodes.
supraclavicular lymph node. Otherwise, it is very difficult to have any palpable lymphadenopathy. You could
Yes,
have
sir.
internal iliac, external iliac, obturator node, para-aortic node,
Aortic
but
nodes.
especially your patient who is 80 kgs, I don't think you can palpate any of the lymph nodes in her. Hmm? So your patient is a diabetic and she is grade 1 obesity also.
Yes, sir.
Yes, next.
Vitals, pulse rate 80 per minute, normal in volume, rhythm, character, no radio radial and radiofemoral delay. Respiratory rate 18 per minute, blood pressure 110 by 70 millimeters of mercury, measured in sitting position in left hand. Patient is febrile and thyroid gland not enlarged and breast normal.
Okay, so here small suggestions, nothing wrong. It's a simple gynec case, no cardiac history, no hypertension or nothing. So you can just say pulse is 80 per minute, respiratory rate 18 per minute, blood pressure 110 by 70. Unless I ask you how you measure, you need not mention it here. Thyroid, breast, okay. Why you left spine? Hello?
Sir, yes,
Ah,
sir.
don't like
Sir,
spine?
uh,
Thyroid, breast and
spine
spine,
is
always
normal,
they
sir,
go
and
together.
okay.
So we usually make a mention of thyroid, breast and spine are normal. So I just casually asked, it is okay. Spine is fine, right? Okay,
Yes, sir.
next.
Abdominal examination, inspection, abdomen is flat, umbilicus in central position, inverted, the skin over abdomen is normal, all quadrants moves equally with respiration, no mass visible, no dilated veins, no scar, no swelling. Palpation, the abdomen is soft, not tender, no mass palpable, no organomegaly.
Hmm.
Percussion, uh, the dullness was present in the liver and splenic area, other areas normal, and auscultation, bowel sounds heard.
One very important thing which you have
No
missed here
shifting
is
dullness.
you always should mention there is no evidence of free fluid in the abdomen.
Okay, sir,
Okay,
okay. No
so
shifting dullness.
yes, and you need not say how you diagnosed. You can straight away say no clinical evidence of free fluid in the abdomen. If
Within
we
the
ask
abdomen.
you, is shifting dullness only the method to find out free fluid in the abdomen?
Fluid thrill.
And what is puddle
No
sign?
shifting dullness. Yes, sir, in knee elbow position for minimal
Yes.
amount of
So there could be a minimal fluid, there
fluid.
could be massive fluid. So depending on the amount of fluid, you would check, not just shifting dullness. So you better mention that no evidence of free fluid in the abdomen.
Fluid.
So this is very important. Okay,
Okay, sir.
right. Now, what else you want to say?
External genitalia, sparse pubic hair seen, labia majora minora normal, no local lesions seen, pervaginal, perrectal, and
Okay.
speculum examination not done.
Okay. Why did you? What exactly you want to look at in the external genitalia?
Sir, in vulval causes, vulval cancer can be seen if exophytic,
Okay. Okay.
and any local infection, local lesions, sir,
Okay.
infections,
Right. See here,
senile vaginitis.
it's a very vaginitis is inside, no? So
Yes,
it's
sir.
very important to do an external genital examination. Ravish is answering urethral caruncle. Again,
Yes, sir.
urethral caruncle needs a bit of separation of the labia minora, sorry, labia majora and minora. You may not be really able to appreciate unless they are too far separated. Here, the importance of external genital examination is to know estrogenization. You said sparse pubic hair. What does it say? Estrogen is less. And you should
Yes, sir.
comment about suprapubic pad of fat. You should tell about the labia majora. Is it atrophic? Is the labia or the labia minora visible? See, labia majora, if normally estrogenized, it will be covering the labia.
Covering the labia minor.
But if the east labia majora becomes atrophic, then they look as if they have moved laterally, and labia minora becomes easily visible. Many a times you can also see the gaping of the introitus in that region. So all these things will tell you that the woman is showing signs of hypoestrogenism. This gives such an important information that even if this turns out to be a case of CA endometrium, I am thinking of the type 2, that is endometrial
Endomet
carcinoma developing in an atrophic endometrium
atrophic endometrium.
where it is not estrogen dependent. Okay, otherwise,
Yes,
there
sir.
is no estrogen at all here. I might be dealing with something else. And as you mentioned, one more word, atrophic vaginitis, that itself could be the cause of some bleeding there.
Yes, sir.
So, always very important to mention the estrogenization signs in the external genitals. And of course, what you said, any lesion you see on the external genitals, any ulcerations also need to be mentioned. Sometimes you may see a prolapse. When you do an external genital examination, you may see a mass coming out. You may see a polyp. So you should be able to differentiate whether it is a polyp or whether it is a prolapse. Okay.
Yes,
Right.
sir.
Chronic inversion, chronic inversion is a condition in which again the fundus is inside out. And in that case also, because of the exposure of the endometrium, you can have postmenopausal bleeding. So these things could be differentiated when you do the external examination. And immediately after external genital examination, we do a speculum examination, look for the vagina, look for the cervix, look for the os, look for any other growth around. Then we do bimanual examination. Madhu, please remember this
Yes, sir.
examination, gynec is called not PV, it is called bimanual
My
examination.
manual examination.
So in the bimanual examination, you are supposed to feel the consistency and the direction of the cervix. You should say cervix is firm in consistency, looking posterior or directed posteriorly, or you say it is soft, it is directed anteriorly, any whatever it is. So that should be mentioned, followed by the size of the uterus, mobility of the uterus, position of the uterus. Three things. For example, uterus is normal sized, atrophic, 8 to 10 weeks, bulky, which means around 6 weeks, and it is mobile, mobility restricted, or totally fixed. Three things. And finally, talk about the adnexa. Adnexa, we usually say right fornix and left fornix.
Left
If
fornix.
nothing is felt, you can say fornices are free, or else you can say right fornix, a mass, of about 6 centimeter by 4 centimeter felt, which is cystic in consistency, has surface smooth, non-tender, or you can say a fixed mass, which is hard in consistency or variable in consistency with soft area and cystic areas, then mobility restricted, whatever it is. So these things in the fornicial examination. So your bimanual examination should be very, very informative. And finally, you do a parrectal examination in which the first sentence should be that the bimanual examination findings were confirmed, and then you talk about the uterosacral ligaments, any fixity, any nodularity of the uterosacrals, and also tell about the sphincter intactness. You have put your finger in the rectum, you will be feeling the external anal sphincter hugging your finger tight. So whether the tone of the thing is good, or is there any kind of atonicity regionally, and talk also about the uh, mucosa, rectal mucosa, whether it is freely moving or fixed to any of the structures. And finally, after removing your fingers from the rectum, you may notice some blood stain. If it is there, you can say the gloved finger was stained with blood, or you can say there is no blood stain. Okay. And
Yes, sir.
during your speculum examination, I think someone mentioned there about caruncle. You should say the periurethral area also looks normal, or you can say there is a small caruncle seen on the posterior wall of the external urethral meatus, if it is there. Prolapse, if it is there, you make a detailed presentation of that condition. Clear?
Yes, sir.
So this completes your examination, and now go to the summary of your examination.
So other systems were normal, sir.
Fine.
Summary: a 53-year-old postmenopausal woman, P2L2, not tubectomized, with chief complaints of bleeding per vaginum on and off since 4 months, which was gradual in onset, progressively increased in duration and quantity, and not associated with clots and abdominal pain. And there was no history of loss of weight and loss of appetite, and a known case of diabetes mellitus for 5 years, and on regular medication. On examination, pallor present. She is obese class 1. Abdomen was soft. No organomegaly seen. No palpable mass seen, and other system examination was normal.
Okay. Now we will just assume you have done a speculum examination and cervix is looking normal. Do you know something about this speculum examination finding? She is a patient of your hospital, I believe. So,
Yes, sir.
are you aware of the speculum examination finding?
I have seen examinations, speculum examination.
No. This particular case, have you seen? Has the speculum examination report written in the case sheet, and you have seen, or have you seen someone examining this patient? No.
Sir, I saw the case sheet, sir, but it was
Was the
normal.
speculum
It was
examination
normal,
normal?
sir.
Fine.
It was
That is
normal,
what I
sir.
anticipated. See, in the very first sentence of your presentation, I said this bleeding looks to be not from the cervix, but from the endometrium. Isn't it? So I'm just confirming the finding now. See, I have kept that this condition is something to do with the body of the uterus, the endometrium, and unlikely that there is any cervical pathology. But still, a speculum examination is mandatory, and I should be getting the finding. It's okay. Let us forget. We will just start thinking of all the possibilities. Now, we will keep the cervical lesion aside. You have done a speculum examination and found that the cervix is looking normal. There was slight bleeding from the os. How do you proceed? Your examination is over now. How do you proceed?
Sir, I would like to do the investigation, sir.
Yes, tell me what you will
do. Sir, for specific investigation, I would like to do transvaginal ultrasound, sir, to look for endometrial thickness and whether there are any adnexal marks
Good.
and
Yes.
polyp,
You
any
can do that.
polyp,
So you want to
any.
do a complete blood count, blood sugar, urea creatinine, urine microscopy. You don't want to do an albumin.
Yes, sir. Urine albumin and deposit.
Only microscopy you have written. Urine albumin, sugar also, because she is a diabetic. We don't know if she has already landed up with any kind of nephropathy.
Nephropathy. Okay,
Yes,
sir.
and urine micro will tell whether there is any microscopic proteinuria and microscopic hematuria.
Actually,
So and infection also, and X-ray examination, ECG examination. All why you want to do X-ray, ECG and things?
sir, X-ray to for metastasis, sir.
No, no, don't straight away
Lung
say
chain.
she is asymptomatic.
And also for anesthetic fitness, sir.
Yeah,
Main
you
X-ray
are
and ECG.
thinking this patient may end up with some surgical
Lung
intervention.
can.
So you are doing all these things. Now we will just try to restrict ourselves to the specific investigation. As you said, you want to do a transvaginal scan. In the transvaginal scan, you will look at the uterine endometrium. You will look at the myometrium also. We have been telling there could be some fibroid in the uterus also, isn't it?
Yes, sir.
So you will look at the myometrium also, and then you will look at the adnexa. Okay, and
Yes, sir.
if your clinical examination has shown that uterus is just normal sized or little bigger than normal, then probably a transvaginal ultrasound may be enough. But otherwise, a transabdominal ultrasound should also be done to rule out free fluid in the abdomen, to look at the liver, spleen, and other structures in the abdominal cavity. Sometimes you may even pick up some of the lymph nodes by your ultrasound examination if they are uh, enlarged. Okay, so
Yes, sir.
not that always TVS is more than enough. You may have to do both TAS and TVS. Yes, you
TBS.
have done that. And which is the most important finding you are looking for in the TVS?
Endometrial thickness, sir.
Okay, you will be looking at the endometrial thickness. Tell me something about that in a postmenopausal woman.
In a postmenopausal woman, if the endometrial thickness is greater than 4 mm, uh,
Hmm.
it is indicates endometrial hyperplasia, sir, which is a pre-malignant condition.
Let us say if it is more than 4 millimeter, it needs further evaluation.
Well,
Let us not categorically
yes,
say
sir.
it is
It's a
suggestive
histological.
of this. No, I need to proceed with further evaluation if it is more than 4 millimeter. Is that clear? Less
Yes,
than
sir.
4 millimeter, you can reassure the patient and leave her. More than 4 millimeter requires further evaluation.
Investigate.
So, how do you evaluate further? Let us say it is 6 millimeters.
Yes, sir. Endomet papillary biopsies.
Okay, the next thing is you want to study the endometrium and you
Endometrium.
want to come to a conclusion. So, what are the ways by which you can study the endometrium? Which is the best way?
Fractional curettage is the best way, sir. And
Mhm.
I can and we can do papillary biopsy and aspiration. DNC can also be done, sir.
Okay.
And
So, the various
uh,
ways of
other
studying
methods,
the
hysteroscope and hysteroscopy and biopsy, and
which is the best
saline
now?
hysteroscopy and biopsy,
Yes.
because we can visualize and
Yeah.
we can take the
Yeah,
biopsy from
only
that there.
hysteroscopy is the best. So, what are the ways by which you can study the endometrium? The non-invasive way is transvaginal ultrasound, and you add little more to that transvaginal ultrasound. You can know the architecture of the endometrium. What is that? What is the test that tells more about the endometrium during ultrasound?
Saline infusion sono.
Very nice, very nice. Sharanya also has answered that. So, saline infusion, sono, hysterogram. saline infusion sonohysterogram,
Histogram.
in which you are going to insert a small Foley's about 8 or 9 F into the cervix, take the balloon just beyond the internal os, fill the balloon with about 3 cc of 3 to 5 maximum cc of distilled water, pull the balloon, it gets snugly fixed onto the internal os. Now through that instill saline, which will distend the endometrial cavity, and when the endometrial cavity is distended, if there is a polyp, or if there is a submucous fibroid, or if there is some irregularity in the endometrium, you can wonderfully see this particular aspect very clearly by your saline sonohysterogram, SSH. And it is very, very, very similar to your hysteroscopy. It gives
Hysteroscopy.
almost the same picture as hysteroscopy. The only disadvantage is that you cannot obtain any biopsy or do anything along with that, isn't it? That's the only disadvantage. But you get to know many of the information what you get by hysteroscopy, the same thing by your SSH, saline sonohysterogram. So these two are relatively non-invasive, transvaginal ultrasound and SSH. The invasive ones, one you mentioned, pipel biopsy, which can be done in the outpatient itself,
Okay.
hardly about 3 millimeter sized plastic cannula with a sharp hole at one of the working tip. So you can just introduce into the cervix, into the endometrial cavity, and the moment you pull out the stillet, it creates a negative pressure and sucks in the endometrium. So that endometrial strip can be sent to the pathologist for studying, and he can give a very reliable report with that strip of endometrium. The next method is, you study endometrium by pap smear, Madhu?
Yes, sir. Endocervical.
See, pap smear involves ectocervix and endocervix, but
Endocervix.
it is said many a times
Not
almost
that much sensitive.
30% of the endometrial pathology can be picked up by a pap smear itself, because even the endometrial cells also get exfoliated and they have to come out through the cervix. It is for the pathologist to differentiate whether I am dealing with endometrial cells or endocervical cells. Both of them look
Cells.
very similar. And you have got some immunohistochemistry studies. It is called IHC. They put some special stains, and especially to differentiate between endometrium and endocervix, they use IHC with vimentin staining, VIMENTIN. So vimentin staining is taken up only by endometrial cells, not by endocervical cells. So if you find those cells in the sheet of cells that you see in the pap smear, you may be able to pick up, but pap smear is not recommended for studying the endometrium. You may be able to get some information. So you have done a pipel. You can also get some endometrial aspiration, right? You can do aspiration of the
Yes, sir.
endometrium, and it is something like you instill some fluid, aspirate it, and get the cells out of that sediment and study the endometrium, right? You can use endometrial brush also, right? And finally, as you said, you can obtain the endometrial sample by one more instrument called Novak's curette, which is a metal instrument very similar to pipel but little bigger than pipel. So around 5 millimeter in diameter, you can introduce into the endometrial cavity and take a strip of endometrium. It is reusable. Pipel is not reusable. And the next thing you said was a DNC. So yes, DNC is one of the classical methods that we use to study the endometrium. The limitation, or the what I should say, there is no need for taking the whole of endometrium for studying the pathology in the endometrium. So this is one argument. So you can just take a strip and examine the endometrium is the argument. But the other argument is if there is a small endometrial carcinoma on the posterior wall and you take this strip from the anterior wall, you may miss the endometrial carcinoma. This is what is the argument. But D&C particularly is not almost abandoned now because it involves so much of removal of the endometrium and is also associated with quite a bit of complications. We are not doing D&C routinely in most of the hospitals now. It is not even recommended. And coming to your fractional curettage is a term that was coined wherein we used to do first pap smear, then we used to take endocervical curettage followed by 5 samples from the endometrium. One anterior wall, one posterior wall, right lateral wall, left lateral wall, and fundus. So 5 samples separately. You take a strip from the anterior wall, put it in the bottle, label it as 1. Posterior wall 2, lateral right lateral 3, left lateral 4, fundus 5. Endocervix should be taken first. First sample should be endocervix. Then that is taken as the first bottle and rest of them 2, 3, 4, 5, 6. Initially you have taken the pap smear. This was called fractional curettage. And fractional curettage was abandoned later for modified fractional curettage. You know the basis of this? Anybody can try to answer me this question. If some postgraduate students are listening to this case discussion, they can try to answer me why from fractional curettage we shifted over to modified fractional curettage. If Madhu can answer, great. Hello? Hello?
Sir, I don't know, sir.
Okay, fine. You say at least that you don't know. I was wondering whether my voice has become muted or any such thing. Anybody? Can anyone try to answer this question? Fine. See, why this kind of treatment, this kind of investigation was done was depending on the site of endometrial cancer that you find, we used to decide about the chances of spread. If there is positivity of the fundal sample, then the chances that it has spread more to the para-aortic lymph nodes and common iliac nodes and also through the round ligament from the cornual side to the inguinal nodes was high. This was the thinking at that time, and depending on that they used to do lymph node dissection. If it is on the anterior wall, again there is a chance that inguinal lymph nodes are more involved. If it is positive of the endocervix, the staging used to be altered. So this is how the fractional curettage was being used to decide what surgery is to be done in which case. But later on, it was found that the evidence has clearly come out that lymph node dissection should be uniform in all the cases wherever it is required. So not that whether it is anterior or posterior or fundal or wherever it is, you are supposed to do dissection of the whole of pelvic nodes and also para-aortic nodes once you see invasion beyond the lower inner half of the myometrial cavity. So once it goes to the outer half of the myometrium, that is 1B onwards, and also if the grade is more than 1, grade 2 and grade 3 cancers should be undergoing lymphadenectomy of all the lymph nodes. So they stopped doing fractional curettage and it was shifted over to modified fractional curettage. Modified fractional curettage is pap smear. Sample 1 is from the endocervix. Sample 2 is from the endometrium. So only 2 samples and 1 pap smear becomes modified fractional curettage. And again here, the endocervical tissue, if it turns out to be positive, the stage was going to be changed earlier. And if it is only limited to the endometrium, then the stage would be different. But you know, the latest staging doesn't consider spread to
Yes,
the endocervix. Only when the cervical stroma is involved, the stage changes. Otherwise, there is no. So even modified fractional curettage is not a valid investigational tool now. And Dr. Madhu, you
sir.
are from Tamil Nadu, and I am talking about the situation that we usually come across in Karnataka, and I keep coming to Tamil Nadu for examination very frequently. Everywhere in Tamil Nadu, I have heard the students answering that you should do fractional curettage. This is the term that is very commonly used, and I always hear from the students what that fractional curettage, the answer that comes out is the procedure that we follow in modified fractional curettage. That is 2 sample plus pap smear. I don't know whether you also have been taught the same way,
No,
but
sir. I only know fractional curettage 5 samples.
5 samples. Okay. So I am sorry if I am hurting the feelings of any of the student here. I just want to give the facts. My intention is not to condemn any of the teacher in this forum. So number one, no role of fractional curettage. Number two, no role of modified fractional curettage also. It is only endometrial biopsy that is required, and if available, I think nowadays most of the hospitals have a hysteroscopy. So doing a hysteroscopically directed biopsy is the gold standard for evaluating the endometrial cavity. So do a hysteroscopy. Of course, we have not evolved so much to use disposable hysteroscopes, so at least we use a 5 mm diagnostic hysteroscope, look at the endometrium, take a small biopsy from the unhealthy looking area, or you may diagnose. See, the beauty of hysteroscopy is you can diagnose a polyp, and if you have the expertise and equipments, remove the polyp then and there itself. If you have a submucous fibroid, remove it then and there itself. If you see an unhealthy area, you take the biopsy from that area. If you see nothing and everything bald, make a diagnosis of atrophic endometrium and come out. Is that clear? This is the story of endometrial evaluation. Scanning, then blind biopsy procedures, and finally biopsy under vision. See and do, visualize and do is the dictum now. Okay, so you
Okay, sir.
have done a biopsy, and what are the reports that you are likely to get?
Um,
Can you answer?
sir,
It goes to the pathologist. You know how it
pathology,
goes to the
yes, sir.
pathologist?
Sir, histology
Okay.
types, whether it is grade 1, grade 2, or grade 3, and whether it's type 1 or type 2 endometrial cancer.
Okay.
If
So
endometrial
your
cancer.
pathologist always use the report as endometrial carcinoma.
No, sir. In cases of endometrial carcinoma, this will be
No, no. I
reported.
asked you what are the reports that you can expect. How do you send the endometrium to the pathologist?
Sir, by fixative for. Sir, in
Hmm?
separate.
Have you seen?
After adding fixatives, a formalin into
No,
in
no.
bottles.
After adding fixative, is it called
Yes, sir.
fixative or preservative?
Preservative, sir.
Yeah, you are going to put it in a small bottle with 10% formalin, and the tissue will be immersed in the 10% formalin, and with a requisition letter wherein you are going to write everything about the history and examination and send the sample to the pathologist. See, I won't go into the details of how you do the DNC, what is the anesthesia that we use. You are supposed to know all these things. These are the simple things that will be asked. We ask you these things to assess whether you have really visited the minor OT and have seen these procedures. I'm very sorry, for the past 7 to 8 months, most of you might not have seen any of these procedures, unfortunately, because of this COVID. But an undergraduate should have seen. I have seen some of the students not even knowing where, in which part of the hospital D&C is done, whether it is done in the minor OT, in the major OT, in the OPD. When we give them a choice, they answer whatever they want. So this should not be the situation. You should be aware of the whole procedure of dilatation and curettage, or endometrial biopsy, or hysteroscopy, or transvaginal ultrasound, whatever we do in the department. Now, the reports of postmenopausal bleeding of the endometrium could come as atrophic endometrium. It can come as proliferative endometrium. It can come as secretory endometrium. It can come as endometrial hyperplasia without atypia, hyperplasia with atypia. There is Srinidhi, forget about simple and complex terms. Nowadays, this simple and complex terms are obsolete. We are telling only hyperplasia with atypia, hyperplasia without atypia. That's all, only two categories, and it can come as endometrial carcinoma. So you have got, these are the varieties, and depending on that, depending on what the report you get, you have to treat the woman. So atrophic endometrium, what you do, if the bleeding is continuing, you can give her hormone
Progesterones.
replacement therapy.
Hormone
Preferably she requires estrogen,
Yes,
right?
sir.
But
Or atrophy.
alone estrogen, if you give, you should be constantly monitoring her endometrial thickness, so you can safely give her continued combination estrogen and
OCT.
progesterone without any break. If you give a break, she will have bleeding. So without any break, you can give for atrophic endometrium. The second thing I said, proliferative endometrium. What does it say? If there is proliferative endometrium, it clearly says still there is some estrogen in her body which is causing the proliferation of the endometrium. So what should you use here? If there is a proliferative endometrium, you have to give her some progesterone, because
Progesterones.
endogenous estrogen, you have to give her some progesterone. So progesterone can be given in the form of oral tablet, can be given as injectable dipomedroxyprogesterone caproate. You can also give it as LNG, IUS, give it as an
Ayurveda.
implant, right? So which is the best way to give?
Sir, LNG IUCD, sir.
LNG IUS, levonorgestrel intrauterine system, which contains 52 milligrams of levonorgestrel, releasing 20 micrograms per day, is the best method, because your patient is quite obese. Any other form of progesterone will have metabolic effects, can worsen her diabetes, can increase her weight. So local method. What's the disadvantage of LNG IUS?
The patient may have spotting.
Patient may have.
Spotting or bleeding, sir, sometimes.
Yeah. She may have some irregular flow for the first 3 to 6 months. Later on, it will settle. The important problem in our country is its cost. It is not available free of cost, so patient has to pay for it, which costs about 3,500 to 4,000 rupees. Okay, so secretory endometrium. If it is secretory endometrium, what does it say? There is a stray ovulation. Sometime ovulation is occurred, or the other thing that you should think is that someone might have given her progesterone. She is bleeding irregularly since 4 months, isn't it? So she must have gone to some person near her house who, for the sake of stopping the bleeding, might have given her some progesterone. So that progesterone might have caused the secretory changes in the endometrium. So it could be iatrogenic or endogenous progesterone due to stray ovulation. Even postmenopausal, occasionally patient can have stray ovulations. Okay, right. Next, the important issues of hyperplasia without atypia, hyperplasia with atypia. These two things should be considered here. So hyperplasia
Yes, sir.
with atypia is very dangerous. There
Dangerous.
could be already associated cancer in some of the areas of the endometrium. So these cases needs to be aggressively treated with total hysterectomy and
Hysterectomy.
bilateral salpingo-oophorectomy.
Oophorectomy.
Okay, so hysterectomy with bilateral salpingo-oophorectomy is the treatment for atypical hyperplasia. Hyperplasia without atypia. So one of the
Progesterone.
student answered simple complex hyperplasia. So please forget the terms simple hyperplasia and complex hyperplasia. Remember, it is just hyperplasia. Is it with atypia or without atypia? With atypia, you are going to do hysterectomy with bilateral salpingo-oophorectomy. Without atypia, you have the option of using progesterone, and very ideal progesterone here is your LNG-IUS.
Yes.
LNG-IUS, even when you use LNG-IUS, you are supposed to do a biopsy once in 6 months. You will be doing in situ, you should be doing biopsy once in 6 months and see whether the hyperplastic changes have reversed. Okay, and if the patient doesn't want it, if two samples at the interval of 6 months has shown normalcy, you can remove the LNG-IUS or ask her to keep it for the total 5 years, during which time probably all these changes would revert and she would do well without any further issues. If after doing all these things for all these benign conditions, if the patient comes with recurrent bleeding, it is ideal to offer her a hysterectomy. Is that clear?
Yes, sir.
So now we go to maybe another 15-20 minutes we will try to spend for endometrial carcinoma. The report has come as endometrial carcinoma. So what else you want to look in the pathology report?
So whether it is type 1 or type 2 and grade.
Okay, you want to know which kind of carcinoma I am dealing with. Is it endometrioid carcinoma?
Carcinoma.
Is it
Clear
adenosquamous carcinoma?
carcinoma.
Is it a clear cell
Clear cell
carcinoma?
papillary.
So you want to know the, yes, papillary carcinoma. You want to know about these things along with grading of the tumor. Is it grade 1, grade 2 or grade 3? Okay, because
Yes.
the pathology will dictate the management. Pathology will decide the prognosis. Pathology will decide about the mode of additional therapy. Isn't it? So it's very important that the pathology interpretation is done properly and also proper action is taken depending on the pathology. Now we will say it is an endometrioid carcinoma, and can you just give me 2-3 differences between type 1 and type 2?
Yes, sir. In type 1, type 2 usually develops on atrophic endometrium and it is not, it is estrogen independent, whereas type 1, the endometrial thickness will be increased and it is estrogen dependent. Type 1 is
Yes.
having good prognosis, whereas type 2 is having bad prognosis. And
More aggressive and
type,
less aggressive. Hmm?
yes, sir.
Yes, and metastasis is very common in the type 2, whereas
Type
type
2.
1 usually present quite early and the cure rate prognosis is better. Fine.
Better.
This much information is excellent for your thing. And now, what is the next step? You have made a diagnosis. The report has come. What is the next thing you want to do?
So surgery is the main staging. Sir, I would like to do CT and MRI, sir. I missed in that.
Which
CT
one you
and
want to do?
MRI.
You want to do CT or you want to do MRI?
Sir, MRI for depth invasion, sir.
Yes.
And CT for lymph nodes, sir.
Beautiful. So, first you want to do MRI or first you want to do CT?
MRI, sir.
Yes, you do an MRI first, find out whether myometrial invasion is there or not. If there is no myometrial invasion, or if the myometrial invasion is less than 50%, there is less than 1% chance of lymph node involvement.
Lymph node metastasis.
So there is no need to do CT scan at all. So always do an MRI first. find out the depth of invasion. If you find that it is stage 1B onwards, beyond that, then you can go for the CT scan to look for any lymph node involvement. That is a very good answer. Wonderful. And just can you quickly tell me the how you stage the endometrial cancer?
Sir, it's a surgical staging, sir.
Mhm.
And sir, I
Do you
want
remember?
stages, sir. Yes, sir.
Stage.
Yes, sir. Yes, sir. Stage 1, it is
Mm.
confined to the uterus. 1A, less than 50% involvement, and 1B, more than 50% involvement.
Of,
Stage
of
2,
what?
of myometrium, sir, of myometrial
Yes,
invasion.
it is an endometrial cancer. Endometrial cancer with less than 50% myometrium invasion or no myometrial invasion.
Invasion.
Both are 1A.
Yes, sir.
More than 50% invasion is 1B. Okay, next.
Stage 2, when it involves the cervical stroma but
Yes.
does not extend beyond the uterus. Stage 3,
See, wait,
stage.
wait.
Yes, sir.
Let us stress the importance of it. You have cervical epithelium and you have stroma. If the endocervical epithelium is involved, the stage does not change. It still remains as 1A or 1B. But when the cervical stroma gets involved, then it becomes stage 2. Yes, further.
Yes, sir. Stage 3, stage 3A.
Mm.
Stage 3 is about local or regional spread of the tumor. In stage 3A,
Yes.
when it involves the adenexa and serosa of the uterus, and stage
Yes.
3B, when it involves the vagina and parametrium.
Very.
Stage 3C, when it
Mm.
involves the lymph nodes. Stage 3A for pelvic nodes. Stage 3CA, one for sorry, sir.
No.
First,
Don't get confused. What you are telling is perfectly fine. 3A
3C1
is serosa and adnexa. 3B is vagina and or
and
parametrium. 3C
parametrium and
is pelvic and para-aortic lymph
parametrium.
nodes. There is subdivision there. 3C. You
C1,
have 3C 1 and 2, isn't
2.
it?
Yes, sir.
1
3C1
and 2.
positive pelvic nodes, and whereas
Only pelvic nodes.
3C2,
2 is
yes, sir.
para-aortic
3
nodes also.
with or without positive pelvic nodes.
Okay. Next.
Yes, sir. Whereas
4.
stage 3-4 is metastasis when involving the adjacent organs. 4A, when the tumor involves bladder and bowel mucosa, and 4B is about distant metastasis and
Yeah.
inguinal
Area
lymph
under
nodes.
study. Yes. Fine. So this is about the staging, and the staging is done one by surgery with the help of pathologist. Can you do it without the help of pathologist? Hello?
Yes, sir.
No, you need the pathologist
Sir,
to. Yes, tell me.
no, sir.
You need the pathologist help. So this staging is called surgico-pathological staging. Okay, so you are going to do the cytology also here, very similar to your ovarian cancer. You will take the cytology from the the peritoneal washings, or if ascites is there, you will do, and you do a hysterectomy with bilateral salpingo-oophorectomy and send the pathology specimen to the pathologist, who will once again look for the invasion. MRI tells us probably it is less than 50%, but pathologist will definitely say whether it is less than 50% or more than 50%. We send all the lymph nodes also to the pathologist, who will say whether they are inflammatory enlargements or cancerous metastatic enlargements. So this way you are supposed to take the help of the pathologist and then finally give the staging of this endometrial carcinoma. Hence, it is called surgico-pathological staging. When you do the biopsy, when you do all these things, everything is normal, but the patient is complaining of bleeding. In that case, you may have to do a sigmoidoscopy. You also may have to do a cystoscopy to rule out pathology in the adjacent organs, which is the cause of bleeding, which will be misinterpreted as postmenopausal bleeding. Now, what are the modes of treatment that you have for endometrial carcinoma?
Surgery, radiotherapy, chemotherapy, sir.
Yes, excellent. The first line of treatment is surgery always, always, most often assisted or supplemented with radiation, and occasionally palliation could be with
Hello?
the chemotherapy. And you have a
Sir,
very
can you hear me,
important,
sir? Hello?
pardon?
Can
Yeah,
you hear me, sir?
I
Okay,
can hear you.
sir.
I can see the slide also.
Okay, sir.
And finally, the important other thing is hormone therapy. Hormone therapy has a very important role in endometrial cancer, especially when it is estrogen dependent tumor and when you want to conserve the uterus. So now, surgery is, what is the hysterectomy that we do here? It is called
Tot-
extrafacial hysterectomy.
yes, sir.
Extrafacial hysterectomy is the term that is given if you people have seen the procedure of hysterectomy. When we open the UV fold of peritoneum, we do a lot of dissection at the bladder base while pushing the bladder away from the lower segment of the uterus, keeping most of the pericervical fascia with the bladder. But here, the pericervical fascia is removed with the uterus. This is called extrafacial hysterectomy with bilateral salpingo-oophorectomy. So this
Oophorectomy.
is the surgery that we use, and depending on the stage and depending on the grade of the tumor. So normally 1A, 1A grade 1 tumor, 1A grade 1 tumor, just hysterectomy is
Hysterectomy.
sufficient. That is extrafacial hysterectomy with
Hysterectomy.
bilateral salpingo-oophorectomy is curative, and the 5-year survival rate could be to the tune of 90 to 95%. Okay, so one of the very important issues with endometrial carcinoma is because 90 to 95% of them will present with bleeding, they immediately rush to the doctor, and most often we diagnose it in either stage 1 or stage 2. Hence, the prognosis of endometrial carcinoma most often is good. It has a good prognosis amongst the other cancers. So here, stage 1A, grade 1, you have a very good prognosis of 90 to 95% with just surgery. And the next one is same 1A, but G2 and G3, grade 2
G3.
and grade 3. So grade is depending on how much of differentiation has occurred. Very well differentiated glandular structure will make it grade 1. Partially differentiated glands along with solid structures is called grade 2. Just sheet of cells wherein no formation of glands are seen properly, it is called grade 3. So grade 2 and grade 3 1A require additional radiotherapy. And again, further, all the other stages with grade would require additional radiotherapy. And radiotherapy is of 3 varieties. One is brachytherapy, wherein you are giving vaginal radiation. The second thing is external beam radiotherapy, which is given from outside mostly to the pelvic region. The third one is whole abdominal radiation, WAR. So these are the 3 varieties of radiation that are administered to an endometrial carcinoma patient. As the grade progresses, usually for grade 3 onwards, you require WAR. Stage 3 onwards, up to stage 2, it is brachytherapy with pelvic radiation, external beam radiation to the pelvis. But beyond that, along with these things, you are supposed to give whole abdominal radiation therapy. And stage 4, usually it is palliative radiotherapy that is given. And of course, the chemosensitizers, especially the platinum based drugs, can be added to improve the results of radiation. Okay, so this is just in brief the treatment schedule for endometrial carcinoma. Now, sometimes you may find endometrial carcinoma. Let me go to the other aspect little after a few minutes. Now, how do you follow these patients after treatment?
Sir, we have to. Hello.
Tell me.
Yes, yes. Sir,
How
we
do
have
you?
to do.
Huh? See, follow-up of the patient is about 3 times in the first 2 years. Every year, you have to follow them once in 4 months for the first 2 years, once in 6 months for the next 3 years. That is total first 5 years. You need frequent follow-up. Follow-up may be symptomatic follow-up, radiational follow-up, or maybe even with ultrasound examinations, you may have to follow them up, and sometimes even CT or MRI could be necessary to look for any recurrences, and recurrence is most often treated with radiotherapy. After 5 years of monitoring, you can follow them up once in a year, right? So first 2 years 4 monthly, next 3 years 6 monthly, and beyond 5 years it is yearly follow. Prognosis, first and second stage, it is more than 70%. Stage 1 is 90%, stage 2 is around 70, but once it reaches stage 3, it falls down to almost 30% and 20% in the stage 3 and stage 4. Now, just a couple of minutes on, if you encounter in a nulliparous reproductive age group woman, I have seen 3 cases. I have seen 3 cases of endometrial carcinoma in 26, 28-year-old women who came with infertility, irregular cycles, and when we did a biopsy, it turned out to be endometrial carcinoma. So can I apply the same principle of treatment for them?
No, sir. Because they
No,
didn't
you
complete
should
their
think of
family.
fertility sparing in these women. So what do we do? Here is one situation where we give them very high dose hormones. So what is the hormone of choice here?
Progesterones.
Progesterone. And progesterone that is most commonly used is
Medrox.
medroxyprogesterone acetate.
Progesterone acetate.
Yeah.
600
And
milligrams a day.
agestrol is the other drug that can be used in the dose of almost 160 to 200 milligrams per day. Students, normally we use about 10 to
10
20
to 20.
milligrams per day of medroxy for a very short period, 3 to 5 days. Whereas in this case, you have to use very high dose progesterone, 160 to 200 milligrams per day for 3 to 6 months, followed by repeat biopsy. And once you repeat the biopsy, if the patient has shown all the changes to be reverted, then encourage her to conceive as quickly as possible. Pregnancy is a progestational stage. It has very high progesterone in her body, and usually during pregnancy, the endometrial cancer will not trouble her. So let her have a child, and once the childbearing is over, quickly do a hysterectomy with oophorectomy. So this is the treatment if you encounter the same condition, endometrial carcinoma, in a very young lady. And if, just for the completion's sake, if you encounter sarcomas, endometrial sarcomas are also known condition,
Yes, sir.
especially endometrial stromal sarcoma, lymphosarcomas of the endometrium carry very bad prognosis. They usually are spread through blood, and again you can encounter them in the younger age group or also in the older age group. Older
Okay.
age group, it is most often surgery. In spite of surgery, the prognosis may not be that good because of the quick spread, hematogenous spread to the distant structures. Okay, so this is in brief about the management, how to work up a case of endometrial, postmenopausal bleeding, and little detail about endometrial cancer. And normally in the examination, if you get a case of postmenopausal bleeding, the discussion usually goes towards the endometrial evaluation. You may be asked in detail about hysteroscopy, procedure of DNC, then scanning and the cutoff of endometrial thickness, and the various reports that you get when you do an endometrial biopsy, and each situation, how it is managed. And especially for a postgraduate, the discussion may totally go towards endometrial carcinoma, and whatever we discuss now should be really more than enough for cutting a good figure in front of the examiners. And if you are able to answer this much, I think Dr. Madhu deserves a very big round of applause. I don't know how much of effort she has put in here to present this case, and also very nice presentation. And she has tried to give a very reasonable, very sensible, and very well academically based answers. And it is postmenopausal bleeding is one of the difficult case to get in the examination for an undergraduate. You did a wonderful job, Madhu, and thanks
Thank
for
you,
the
sir.
White Army also for giving me this opportunity. Hope we can conclude. If there are any questions, we can take those questions, or else we will conclude the session.
Sir, in the Zoom, there are no questions. Shravan could tell us if there are any questions in the YouTube streaming. Okay, sir. So there's nothing on YouTube also. Thank you so much,
Thank you.
sir. It was indeed a clinical presentation. And with the great guidance from mentor, sir, it went well. With the great presentation of the presenter, we all could learn a lot from the presentation. And thank you to all the participants who were really active in the chat box. Sir, we will always need your guidance, blessings, and support. Thank you so much, sir, for giving us this presentation.
Thank you, the whole team. Bye.